right. I really want to acknowledge Andy Duker. Dr. Duker has been instrumental in making this happen. Of course, Lori Selm deserves all the credit that Dr. Duker gave her, but I'm going to give Dr. Duker really all the credit for keeping this going. So thank you, Dr. Duker. All right. So it is my pleasure to tell you a little bit about what is this thing called the Cincinnati Cohort Biomarker Program, and where are we now? And so my disclosures are here. I trust that none of them particularly are relevant to what we will discuss. But the concept of the CCBP was born out of this idea that somehow we knew what Parkinson's is. And 200 years after the seminal discovery or the presentation of what Parkinson's was by Dr. James Parkinson in 1817, there was someone who said, we're very close to putting together Parkinson's as a puzzle. And in fact, there were papers that were published showing the actual puzzle of Parkinson's. And this is one of them. This is probably the one that I most often refer to, because this was done using an artificial intelligence algorithm to generate an actual puzzle and saying, here, this is what Parkinson's is. And the trouble with the concept of Parkinson's as a one puzzle is, of course, that you have to think about it in terms of what are the pieces and how do they fit together, and more importantly, how many more pieces before we see the puzzle coming to full view. So when we looked at this, we also want to ensure that if this is a puzzle, that somehow all these interlocking pieces are quite tied together. I'm having here a way of illustrating that they don't quite fit together. We want them to fit together. But when we really think through this idea of a puzzle, what we probably should be thinking of is the translation of what you already know, which is that there may be as many puzzles as people living with Parkinson's. That this is not one puzzle, but many, and that perhaps each of them individually relate to a specific kind of puzzle or molecular biological change that drives each individual, which is what gives rise to what the rest of medicine refers to as precision medicine. The idea that you're treated according to the type of biology that drives what you have. So in this idea of a puzzle, though, we've come to think of Parkinson's by that which is a common denominator to everyone. And the common denominator to everyone is the synuclein that aggregates into what we call Lewy bodies and the deficiency of dopamine. And these are convergence biomarkers. If we group people with Parkinson's, we know that most of them, perhaps not all, but most of them will have Lewy bodies in the brain, and there will be dopamine deficiency, which the latter is the reason why we have been doing a reasonable job in terms of treating people with Parkinson's, because we can elevate the tone of dopamine in the brain via levodopa. But these are not relevant as the causes. We don't say Parkinson's is caused by dopamine deficiency, nor should we say Parkinson's is caused by Lewy bodies. There is an association that is not causation. And actually, it turns out that I'm showing this little diagram to the left to remind us that once we began to use different types of stainings on the brains of people who had Parkinson's, it turns out that synuclein is one of many pathologies. So this is not about just Lewy bodies, but about many other proteins in the brain. And yet we've insisted that we know what Parkinson's is if there is someone who has features that are consistent with the clinical criteria of Parkinson's, that somehow have dopamine deficiency and a measure of synuclein somewhere. So let's try to think through how is it that we are changing the world is by recognizing the folly of what we do today. And that is that based on the features that you have at the clinic, based on the observations made by someone like me, a doctor, we can say, trust me, you have Parkinson's disease because you check all the boxes, and let's face it, I'm an expert. Trust me. Quaint for the 20th century, we should not be allowed to do this in the 21st, as much as we love the trust that you have on us. So when we then have people that are fitting into a bucket of Parkinson's because we're asking them to come into the biomarker program, as those have been called, and then we create a different bucket called controls, people who we really don't know what they have, so we figure they don't have anything neurological. So we call them controls. And we use statistical techniques to be able to distinguish what is it that separates one group from the other. And in that process, we then call those things that statistically correlate with Parkinson's a biomarker of Parkinson's. How have we done with this paradigm? Not very well, because if we all know that everyone is different and comes into Parkinson's in a very unique way, then that which is common statistically would not be expected to be relevant as the cause of the problem at the individual level. So this is the list of the many drugs that are in the pipeline for Parkinson's. So let me make the case that it is not that there isn't enough investment into Parkinson's. There's plenty of investment. It's just how we're using it. And at the top of this, this is just a year apart, by the way. You can see that this circle has all these faces concentrically as layers, and anything on top is disease-modifying, and anything below is symptomatic treatments. We think that the disease modification is just a level above symptomatic therapy. That if we were able to find levodopa to succeed, we're going to find something else, like levodopa, but that will slow the progression of everyone. So what we then have is a graveyard of therapies. When they get all the way to a phase 3 trial, none of them work. And we say, well, the problem, though, is that we are just not doing trials well enough. Typically, the lessons have been, we just don't have good trials. If the trials were great, if they were perfect, we know that these drugs would have been shown to be effective. As opposed to saying, gosh, maybe there is a problem here. Nothing works, and the trials are as good as they can be. Nothing in life is perfect, but perhaps it's an issue that relates to the basic mismatch between who is receiving what. So when you're invited to any trial, if I'm the one invited into a trial and say, there is a trial that we have at the University of Cincinnati that uses a drug that has actually cured mice from Parkinson's, and we think it's going to do the same for people. Your question to your doctor asking, if it's me, I don't think you're going to hear that from me, but if it were somebody like me, you have to say, why me? Why are you inviting me to this trial? And if the answer is because you have Parkinson's and it's an early stage Parkinson's, it's the wrong answer. You want to find out what is it about me that makes me a candidate for the mechanism of action of the therapy that you're asking me to test. And that's why one of the proposals we've made is that every future trial of disease modification must have a first check box of a bioassay. A bioassay is a test that you can deploy in blood that tells what kind of mechanism is being interacted with or modified by the intervention one is meaning to test. And is there an assay that would link people who are being assessed for their candidacy to a trial to the medication we're trying to do. And that right now is missing in most studies. The one exception, believe it or not, was this trial that I want to just briefly touch on, which is the Innocent trial. Turns out that low urate has been thought to be, for many years, a risk for Parkinson's. The lower the urate, the uric acid, the higher the risk for Parkinson's. And vice versa. The higher the urate levels, the lower the risk. Furthermore, people who have Parkinson's disease actually have a really good Parkinson's type if their levels of urate are high. So for instance, gout is a condition that raises the urate levels, and that brand of Parkinson's, for the few people that go on to develop Parkinson's, is really good. Conversely, those who have low urate have a rapid progression. So it was only natural to do a trial, and so far the only one that selected individuals on the basis of what kind of levels of urate they have. And if they were low, they would come into unison to try to increase it. Well, this is the graph of the trial. The trial succeeded in terms of elevating the levels of urate. But this is what happened to people. Nothing. There was no change. This is 40% of the pie of Parkinson's. In other words, 4 out of 10 individuals with Parkinson's have low urate. And we thought that was a cause. That isn't a cause. 40%, it turns out, is too large a chunk of the biological universe of Parkinson's. And so we were, even here, in the only exception to the rule that we never match people to the therapies that we're interested, even here, we did not get there. So we really need to ensure that we need to move from this to something that's a lot more individualized, and that's the Cincinnati Cohort Biomarker Program. I want to really acknowledge Ben Stetcher, who was one of our early supporters of this. I'm glad that he's going to be talking just after me to you. He's right here. He came from Toronto last night, so I'm very happy to hear him speak about this. But he's someone who actually came to Cincinnati because loved the concept, and we were then doing the very first recruitment strategies for this. This is what we want to essentially do is have what other fields of medicine have done, which is a platform for molecular subtyping. And essentially is the search of what is it that at an individual level is driving the disease. It is a fishing expedition, which is has a bad reputation in science. You need to know what you're looking for. Hypothesis-driven research. And it's developing assays of therapies that we've already tested, that we know are great molecules, we just never knew who they were for. So that then what we would end up doing is having an individual be told at the bedside, you have Parkinson's, we have no idea what that means to you. We would have to do a variety of different tests to identify where is it that you are in the spectrum of the different abnormalities, so that then we can determine what kind of Parkinson's you have. And notice that this is no different to what somebody in oncology would be told, right? You have breast cancer. I have no idea what you have. We would need to do a variety of different tests to be able to know what is it that you have, so that then we can treat you. We skip all of that. We could then say we're going to treat you once we know what you have molecularly. Meanwhile, here's levodopa to make you feel better. And so through this program, we have a growing set of collaborators that are helping us getting to this point, to be able to go through that stage into the biotyping of individuals. And so we, as you can see here, and this is where we are now in terms of recruitment, we've passed 800 subjects. Many of you are part of this program, so I wanted to thank you for this. Our goal will be that in a few years we will be saying to at least some of you, we know why. We know why you have Parkinson's. We've never answered that question. All of you have asked us, why do I have Parkinson's? Well, we know why we think everyone develops Parkinson's, but we have no idea about you. This is the way to do that. This is a summary of ongoing partnerships and data analysis. I won't go through them, simply just to tell you that it will take a village, and that we need, of course, to continue growing this, because it is the future. For now, it's a research program. In the future, we hope it will become a platform for all patients so that they can come in and be treated according to the biological driver of their brand of Parkinson's. So that we will then have a tailored approach that no longer uses the proteinopathy concept, that Lewy bodies are the problem here, that moves from convergence biomarkers to divergence biomarkers, that actually looks not how you are equal to others, but how you are different from others, and that matches therapies according to your biology. So that in the future, we would have a situation where clinical trials will not be hundreds of people, but it might be tens of people or fewer, because it is very likely that the first success will be small. But we have to have any success, and we can grow it. And there are examples in many other fields of medicine where the success began in a small but very robust fashion, and then that grew. Thank you.